So I'm going to be, my name is Ratan. I'm an associate professor at MD Anderson Cancer Center in Houston. I'm going to be talking to you today about a big topic, which is standard therapies for sarcoma. So Dr. Agulnik and Dr. Forsher are going to be talking with you later about some targeted therapies, immunotherapy and experimental agents, but I'm going to be chatting with you about some of the old standbys, which are still sort of the mainstay of treatment for many patients with soft tissue sarcomas. I have some disclosures. I do work with some pharmaceutical companies in the course of my work. I don't think any of this is likely to impact what I'm talking with you about today. And as Gina was just chatting with you all about, just so that we're all dealing with the same set of facts here, sarcomas are a group of diseases, not just one disease, over 50 different subtypes. And all of them put together account for about 1% of cancers in adults. So what that means is that if you are a great oncologist in clinical practice, seeing the cancers that occur in your community, breast cancer, colon cancer, lung cancer, you may see sarcomas uncommonly and a specific subtype of sarcoma, maybe even once or twice over the course of a career. So fortunately, we have guidelines that exist on a national level to help doctors make reasonable choices regarding treatments for their patients. And the most commonly cited guidelines in the United States are the NCN Guidelines, which are detailed. They're assembled by experts, including some of the folks who will be chatting with you today, and they're updated frequently as things change in the field. So they're actually a great resource for practicing oncologists. That being said, it can be really difficult to have all of the necessary context to sort of make the optimal decision for a patient's treatment, even using those guidelines, if you don't see these cancers frequently and sort of keep up with the background that is involved in their formation. So nccn.org is the website where physicians access these guidelines. They also have a great patient education session. They have patient education materials, including for sarcomas. And I think it's great for folks who are looking for a little bit more detail. So something that you may consider checking out. And I'm going to be talking to you about systemic treatments, and that's in contrast to local therapies. So later on this weekend, you're going to be hearing about treatment with radiation and surgery, both of which are extremely important in the treatment of soft tissue sarcoma, but are limited in that they only treat a specific location in the body. So if you do surgery on a tumor in someone's thigh, you've removed that tumor in their thigh, but you have not done anything, for example, to address cancer that might be in the lungs. Systemic therapy is different. It's medicine that is put into the bloodstream. So it's either administered by mouth or by IV, but ultimately ends up in the blood and is then delivered to everywhere where blood goes in your body. So it's a way to attack any lesions that might be seen on a CAT scan in metastatic patients where surgery is not an option. And it can also attack microscopic disease that you don't see on a CAT scan, but might be there and cause problems in the future. And we'll talk a little bit at the end of this talk about adjuvant systemic treatment, which is giving chemotherapy to someone who doesn't have metastatic disease, who has a tumor just in one spot, but is at high risk for ultimately developing metastases in the future. And we'll talk a little bit about that later on. So there's a lot of different medicines that we use to treat sarcoma, and thankfully that list is growing over time. What I'm going to be talking with you about most today is what we call traditional cytotoxic chemotherapy. Cytotoxic means it kills dividing cells. The way that traditional chemotherapy works is it attacks the machinery that is used by cells to grow and divide, to do things like duplicate their DNA, to get larger, and so forth. And because it attacks the machinery that cells use to divide, it can also impact cells in your body that divide rapidly. And so the side effects from chemotherapy that some of us are accustomed to thinking about are a consequence of that. So chemotherapy agents that cause you to lose your hair, you lose your hair because the cells that make hair divide rapidly and are sensitive to these medications the same way the cancer is. That's also true for the cells in the bone marrow that make your blood, and also true to some extent for the cells that are important in providing you with fertility. Targeted agents are different. These inhibit specific genes or proteins that the cancer can use to grow or to feed itself. In standard sarcoma therapies, the most targeted agents we use are directed at blood vessel formation. So tumors that are growing need to form new blood vessels in order to feed themselves. And we have approved targeted therapies which inhibit that process. And so the side effect of those targeted agents are blood vessel related issues, things like high blood pressure, complications with wound healing, and some of them can cause skin rashes and skin changes. Other targeted therapies, many of which are investigational, will have other side effects. And then immunotherapy, which I understand Dr. Forsher will be talking about later on, is yet another type of treatment, which has become kind of a hot topic in cancer, but for sarcoma still remains something of an experiment in most sarcoma subtypes, although it's becoming more commonly used in specific cases. The most common type of immunotherapy you hear about on the news is checkpoint blockade. This is the type of immunotherapy that revolutionized the treatment of melanoma and has made significant contributions to the care of patients with other types of cancers. In sarcoma, it is used some, but it is typically not the first thing that patients are given outside of some very specific circumstances. The side effects of immunotherapy are what you might expect. The immune system is revved up to try to recognize the cancer. And so in that process can also start to recognize parts of your own body, and you can get what we call autoimmune diseases. The most common sets of these are typically hormonal problems or problems with the gut. People can get diarrhea or even bloody diarrhea, which we call colitis. But again, this is an emerging area, which you'll hear more about later on. These are just some examples of drugs in each of those different categories. And I'm going to be focusing mostly on the top here in the ones in red, just because there's enough to talk about with these three. And I've only got 20 minutes, but I'm happy to sort of answer questions later on some of the other ones as well. So if you go to these NCCN guidelines and you open them up and you try to see, okay, well, I have a new patient with metastatic sarcoma. What am I supposed to give them? It is going to list out over 10 options for you. And part of my job as a sarcoma expert is to be able to understand where you would use one of those versus another. And I'm going to try to share with you some of the data behind that decision-making process. And as Gina mentioned, the data that we have for sarcoma is imperfect. These are smaller studies. There's lots of different subtypes. And so reasonable sarcoma experts can sometimes disagree on what an appropriate therapy is. So I'm going to try to focus on areas of agreement, but then also sort of highlight some areas where a second opinion might result in a different answer for you. And for the purposes of time, I'm going to focus now specifically on doxorubicin, which you will notice is in basically all of the recommended frontline treatments for metastatic sarcoma. I put epirubicin in orange there because epirubicin is a cousin of doxorubicin, which I think you can think of as interchangeable. It's used more commonly in Europe, but it's available in the US as well. So doxorubicin, some of you, when I bring this up in the clinic, people often talk about it as the red devil, and I think that's an unfortunate name, but we can talk about where that comes from. It is a derivative of a compound that's isolated from soil bacteria. I think patients are sometimes surprised to hear that a lot of the treatments that we use to treat cancer are derived from natural products. They are refined, they are purified, but this is one example. And it works by interfering with the replication of DNA. Side effects of doxorubicin, and this is not all the side effects, but some of the important ones. One I'll mention right off the bat is nausea. So patients who got doxorubicin in the 1980s and 1990s to treat their breast cancer or their sarcoma experienced really crippling nausea as one of the side effects. And what's changed in the last 20 years is that we have really, really outstanding nausea medicines that just about everybody gets in the IV prior to getting doxorubicin. So when I'm counseling my patients, I typically tell them, this can make you nauseous. We're going to give you medicine. I don't expect you to be vomiting at home. It's possible you may not be hungry for a few days. If you are vomiting or if your nausea is out of control, let me know. I have some things that I can do that are likely to help you get that under control. Mouth sores can happen. We'll talk about that again in a second. Weakening of the heart muscle is an important side effect. It's not the most common. We don't see it in every single patient, but it's something that we think about when we're administering doxorubicin. And it can impact the bone marrow, as we talked about before. And like many chemotherapy drugs, there is a low but real possibility of developing a second cancer, typically of the blood, as a consequence of getting the chemotherapy. And doxorubicin is not just a sarcoma drug. It's used to treat a lot of different cancers, breast cancers, leukemias, and lymphomas, among others. And one thing we learned early on when we were using doxorubicin to treat sarcoma, so this is data from the 1970s, is that specifically for sarcoma and different from other cancers that are more common, the more doxorubicin you give, the more likely it is to work. So with lymphoma and breast cancer, which are two cancers where doxorubicin is commonly used in the community, once you get to a certain threshold level, you don't need to go higher to sort of get the maximal response rate. Whereas sarcoma, the higher you go, the more likely it is to work. And so what we're limited by then is toxicity. We want to make sure that we're not giving a dose that is unsafe for a patient, but we do give higher doses of this medication for sarcoma than we do for other cancers. And this is one of the things that we sometimes see community oncologists, even really great ones, sometimes a little bit uncomfortable with because it's not typically dosed this way in other cancers that are more common. Looking at it another way, I'm just showing you here that when you start at a dose of 45 milligrams per meter squared, the response rate is less than 20%, and it goes to near 40% using these criteria, which are old, in patients that have 75. And I'll mention just very briefly, I'm going to be talking about response rates and things like that during this talk. Response rates are not how many patients benefit. They're very dependent on the way that you define response in a specific trial. So use it to compare one number to another in a specific study, but don't use it to determine how likely you are to benefit from a treatment, if that makes sense. Another issue that comes up with doxorubicin, because we give such high doses, both at one time for one cycle and cumulatively over a patient's life, is the increased risk of cardiac toxicity. So if you're treating a lymphoma or a breast cancer, it is typical to give doxorubicin as a 15-minute infusion in the infusion center. And the truth is that that's probably fine, because the lifetime dose of doxorubicin that you're likely to receive is going to be well below what we feel is unsafe. For sarcomas, it's not uncommon for our patients to get up to higher doses that are closer to this theoretical lifetime maximum that oncologists keep in mind. And so there are strategies that can be used and are used not totally uniformly to try to decrease the impact of doxorubicin on a patient's heart. And it's important because it allows us potentially to go back and use doxorubicin again in the future if we need to. And the two major ways of doing this are to increase the infusion time. So sometimes doxorubicin, instead of giving over 15 minutes, is given over anywhere from 48 to 72 hours. That is felt to be cardioprotective, but it does increase the risk of mouth sores, and that really can be a problem sometimes. I mean, bad mouth sores can land somebody in the hospital for a few days because they're having a hard time eating and drinking and they have a fever. Another way to protect the heart is with the use of a medicine called Doxorubicin. The brand name is Zenocard. It's an expensive medication, but it is usually covered by insurance. And there's been theoretical concerns that, well, if we're protecting the heart muscle, what if we're protecting the tumor from the chemotherapy as well? And there's increasing data out there that that's probably not true. Cancer outcomes are probably similar, but that has been a theoretical concern that has sometimes limited uptake of this use of this medicine. And so what I would say is that even in sarcoma centers, even among people who know what they're talking about, practices around cardioprotection can be variable. But it's not an unreasonable thing to talk with your doctor about. There isn't a right answer here, but there is something to think about. The other thing that comes up with doxorubicin is, how do you use it? Do you use it alone, or do you use it in combination with additional drugs? And so doxorubicin, as we started studying it in the 1970s, one of the first combinations that we looked at was a second drug called dacarbazine, which is still considered one of the frontline options in the guidelines. And what we saw in these old studies, on the left here, you can see 1977, 1983, 1987, is that when you add doxorubicin and dacarbazine and compare it to doxorubicin alone, you have a higher response rate. That's the middle column, and response rate is the chances that the tumors shrink. You have a higher complete response rate, which is not common in sarcomas, but a higher chance that the tumors disappear altogether. Now, I would state that those are not cured patients. They're just patients where the tumors disappear for a period of time. But we've never shown that that combination actually makes patients live longer. And I'm not going to go into this, but it can be very difficult to show that in a clinical trial because our trials are small. But we do care about that. But just to show you what that looks like, this is a patient of mine who had a leiomyosarcoma, who had, on the left-hand side here, you can see right in the middle there is the heart. On the left, you've got a large tumor. That's that white area in the middle of the black lung. And you also have one on the right. This is a patient who was very symptomatic from her disease. She had pain, she had shortness of breath. After 2 rounds of chemotherapy with doxorubicin and dacarbazine, by giving her a combination instead of doxorubicin by itself, I caused her more side effects from chemotherapy, but she actually felt a lot better because the tumor shrunk, she didn't have the pain, her breathing improved. So an example of what a response to treatment can do, even if that overall survival benefit's not so clear. More commonly these days, especially in fit patients, the drug that we use in combination with doxorubicin is a drug called ifosfamide, okay? That's been around since the 1970s, but when it was initially developed, it caused bleeding in the bladder at the doses that we need to use in order to treat patients. In the 1980s, a compound called Mesna was developed, which basically solves that problem for the majority of patients. And so ifosfamide started to get studied in sarcoma back then. And in addition to the bleeding in the bladder, ifosfamide has 2 specific side effects, which are sort of unique to it. One is the possibility of causing kidney injury. We typically don't use a lot of ifosfamide in patients that don't have great kidney function, or in patients who who are on the older side because they're going to be at risk for kidney damage. It can also cause neurological side effects, confusion, and other things, which I'm not going to go into right now, but that is a specific side effect of ifosfamide. And then it has other side effects like nausea, like bone marrow suppression, which overlap with doxorubicin. Ifosfamide, like doxorubicin, is used to treat a number of different cancers. And like doxorubicin, the more ifosfamide you give, the more likely it is to work. And so we are generally trying to push the doses of this medication as well. So the most common sort of combination regimen that we use in younger fit patients these days is doxorubicin and ifosfamide, and it's also referred to as AIM, adriamycin being another name for doxorubicin, and the M stands for Mesna. And this regimen is made possible by the development of these medications called growth factors. So some of you who've taken chemotherapy may remember getting a shot after your chemotherapy, which helps your body recover from the chemo. That shot is what makes chemotherapy like this, which is high dose and intensive, safe to give. And we know that when we add ifosfamide to doxorubicin alone, you shrink more tumors, nearly double in one recent clinical trial, but again, have never actually shown that patients ultimately live longer if you give the two drugs together versus maybe giving doxorubicin and then using ifosfamide someday in the future. But for patients who need their tumors to shrink, this has been like the de facto regimen for fit patients with good kidney function who are candidates for it. The concerns with combination chemotherapy, and this is a place where this is an area where you can get different opinions at different sarcoma centers, is that even though it is not controversial that doxorubicin plus another drug results in a higher response rate, it definitely comes at the price of more side effects, more likelihood of ending up in the hospital, higher rate of requiring blood transfusions. And so for a given patient, that may or may not be in keeping with their goals. And so what's not controversial is that if you have to shrink a tumor, either to get someone to surgery or make symptoms better, combination therapy is more likely to do it. But for that patient who is asymptomatic with metastatic disease, for that patient who really needs to continue to work or really wants to continue to participate in activities that would not be possible with more aggressive chemotherapy, doxorubicin alone is a very sensible choice. But what I would say is that whether you do chemotherapy with doxorubicin by itself or in combination, getting the dosing right is really important. And then asking the question around cardioprotection is something else that we typically discuss and something I'm able to provide to a patient that comes to see me for an opinion that might not necessarily be on the radar of someone who typically uses doxorubicin at lower doses for more common cancers. The other area I wanted to chat with you about today is what's called adjuvant systemic therapy. So this is a complicated topic, but it's a common scenario in the clinic, is that you have a patient that comes to see you. Let's say they have a tumor in their leg and you do CAT scans and there's no cancer visible everywhere else. So the impulse, and often the standard, is to do surgery with or without radiation as a way of removing that tumor. And then the patient's scans are clear and the hope is that the patient is cured. But we recognize that there are some patients that probably already have microscopic cancer that has spread to other parts of their body, for sarcoma, most commonly the lungs, and that if you don't do something to try to mop up that microscopic disease, those patients are going to recur. And that is what's called adjuvant chemotherapy, when you give chemotherapy either before or after a surgery with the goal of destroying any microscopic cancer that might have left the tumor and set up shop other places in the body. And the key considerations here are that you want to make sure that you can identify a patient who's at high risk for that to happen. You want to make sure you have a treatment that actually meaningfully lowers that risk. And you don't want to treat a patient who is likely to be cured with surgery alone. These are hard drugs. They have side effects, both short-term and long-term. So you don't want to treat somebody unnecessarily. So how do you think about risk when it comes to a localized sarcoma? Well, if you go back 30 or 40 years, the way that we've done it historically is by looking at the grade of the tumor. And sarcoma grading is different from staging. Staging is about how advanced the tumor is in terms of the size of the tumor and whether it's spread. Grading is about what it looks like under the microscope. And so a low-grade tumor or a grade 1 tumor, if you look at the left column here, by definition is expected not to metastasize. Now, can you find exceptions to that? Probably yes, but by and large, a low-grade tumor does not have metastatic potential. You're usually not going to be talking about doing adjuvant chemotherapy. In contrast, for high-grade tumors, you're saying, at least based on the way it looks under the microscope, this is a tumor that could spread. And then after grading, the next best indicator we have of how likely the tumor is to spread is the size. So if you look at this table, the right-hand column here, for intermediate or grade 2 and high-grade tumors, as a tumor gets larger, the rate of metastatic disease increases. So a large tumor is going to be higher risk than a small tumor if they're both high-grade. And then, of course, you can get more sophisticated about this. And so a group from Europe has come up with this app for your phone, and it's a calculator that incorporates a number of different variables, including the size of the tumor, the grade of the tumor, the type of sarcoma that it is, and its location, to give you a number of how likely that tumor is to show up as a distant metastasis in the future. Now, this is not perfect. Many of the patients I see in clinic cannot be plugged into this app, but it can give you a way of starting to think about what are the risk factors that help you make the decision as to who's high risk. Adjuvant chemotherapy for sarcoma has been controversial. Whenever you go to a meeting of experts, there's usually a point-counterpoint discussion of whether or not we should be doing chemotherapy in this setting and for whom. And the reason it's been controversial is that these trials are really difficult to do. When you do a trial in sarcomas, you're talking about 50 different diseases, and the ones that are specifically enrolled in a trial are going to impact what the outcome of that trial is. If you put a bunch of patients on the study that have a subtype of sarcoma like gastrointestinal stromal tumor, which doesn't respond to chemotherapy, it is not going to show you a benefit. And that was a problem with some studies that were done decades ago. There's also an issue where if I'm a physician taking care of a patient who comes to see me, and I feel that patient's at really high risk for their cancer coming back, I don't want to put them on a trial where they either get chemotherapy or no chemotherapy, because if I think chemotherapy helps them, I don't want to give them no treatment. So there's been discomfort putting patients on a study like that. And so for all of these reasons, historically, there have been very few studies that actually show that giving chemotherapy definitely prevents a tumor from coming back. Here's an example of a negative study. So this is EORTC 62931, catchy name, I know. And this is a study that is using a modern chemotherapy regimen, doxorubicin and ifosfamide, giving half the patients that and giving half the patients no chemotherapy at all. So the blue line here, the left line here is survival, and this is years on the bottom here. So what you would want to see is that if chemotherapy was helping these patients, you would want to see the blue line up higher than the red line. That would tell you that chemotherapy is ultimately helping those patients live longer. But that's not what this study showed. And so 2012, the message was chemotherapy doesn't help these patients. But the key critique when we look at this study is that the patients that were put on the study were not particularly high risk for having their cancer come back. Most of the patients were not high grade, and many of the patients had small tumors. So what if you take that circulator that we talked about before and actually try to look at just the high-risk patients, or look at the whole patient population? What does that look like? Well, it turns out that 60% of the patients that were put on that negative study had a very low risk of their cancer coming back. And that's the green lines that you see at the top. The solid line is no chemotherapy. The dashed line is with chemotherapy. And you can see they do about the same. For low-risk patients, chemotherapy doesn't help them. But if you're a high-risk patient, the way they defined it in the study, if you're someone who's at a high risk of having their cancer come back and causing them to die, that's the red lines here. And you can see the dashed red line is clearly higher than the solid red line. So for patients that are at high risk of having their cancer come back, chemotherapy can be helpful. And without belaboring the point, we now finally have another study that looked at giving chemotherapy versus giving another ultimately less effective chemotherapy, which confirmed that in patients that have a high risk of their cancer coming back and have a tumor type that's sensitive to chemotherapy, giving chemotherapy after surgery and radiation or before surgery and radiation can actually result in more cures. But it's still a controversial topic. Who's high risk enough? Who should get chemotherapy and who shouldn't? You're going to get different opinions on that, even at major sarcoma centers. MD Anderson, we give a lot more chemotherapy than some other very smart and very well-respected sarcoma centers. So this is a place, especially if your tumor is on the margins in terms of risk, where you may get different answers. If you're going to do chemotherapy, combination doxorubicin-based chemotherapy is the standard. So usually ifosfamide, but for patients who can't get it, dacarbazine is an option as well. So that's sort of what I wanted to cover with you today, recognizing that I wanted to leave some time for questions. But parting thoughts would be that, as Gina mentioned in her last talk, consulting with a sarcoma specialist is really important. And the things that I feel that I'm often able to provide to patients that are under the care of great oncologists in the community that don't see a lot of sarcoma is choosing the right drugs, making sure the dosing is correct, talking about protecting the heart, and then for those patients with localized tumors that have not spread, talking about the appropriateness of giving chemotherapy either before or after surgery in order to increase their chance of cure. Many times, the treatments that I recommend can be administered locally. There are rare exceptions to that, and there are some that are intermediate, drugs that can be given in the community but require more monitoring than treatments for some other more common cancers. And just to piggyback on what Gina was talking about earlier and one of the questions that she answered, second opinions can be helpful. And I guess what I would say is, it's not insulting to have a patient come and tell you that they're seeking a second opinion. It's fine. It's a good thing. You don't have to be shy about it. I have managed patients with Dr. D'Amato. I've managed patients with Dr. Agolnik, I believe with Dr. Forsher as well. It's actually nice to be able to catch up with them. And ultimately, despite no matter how much we care about you, your outcome from your sarcoma treatment belongs to you. And what's most important to me as a doctor taking care of you is that you have confidence in your care plan and that you are at peace with having done everything that you need to do to have that confidence, right? And so, ultimately, you need to make sure you understand who's driving. It can be muddy if that's not so clear. But I would be very nervous around anyone who tells you absolutely don't get a second opinion. But I would agree with Gina where I say where you get that opinion makes a difference. You do want to go to a place with expertise. And the Alliance and other patient care organizations can give you some guidance as to where those places and where those specialists are. And I'll stop there and open it up to questions.
Excellent. Thank you very much, Dr. Ratan. We'll take a few questions right now. Oops.
Dr. Ratan, one of the questions in the chat is, what causes resistance to chemotherapy?
So it's a complicated topic, and the mechanisms that cancers can use to evade the treatments that we give are, there's lots of them and they're complicated, and it ranges from everything from pumps that can literally pump chemotherapy out of cells to changes in the proteins that are targeted by specific agents so that those agents don't work anymore. There's lots of mechanisms. That's a complicated area. What I would tell you though is that every treatment that we give, even if it kills 99% of cells, your cancer is constantly changing. And so if there's a population of cells or one cell that's not sensitive to the chemotherapy, once you start applying chemo, the other cells will die and that one will tend to predominate. And that's the process that ultimately takes place in most patients' cancers. So unfortunately for metastatic patients, most chemotherapy agents don't work forever. I saw a question of how long they do work, and that's a very variable question. Sometimes they don't work at all. Sometimes they work for years and years and years. And I think without wanting to speak to anyone's situation, I think it can be hard to predict that.
I have another question about Yondelis.
Yeah, so Yondelis is another sort of cytotoxic chemo. It was on my list. Trabectedin is the generic name. In the United States, trabectedin is approved for the treatment of liposarcomas and leiomyosarcomas. It may have some activity in other sarcomas as well, but it's been best studied in those two subtypes. And it's generally used as a later line of therapy. And the reason for that primarily is that other drugs tend to work well. Yondelis does seem to have a specific role in the treatment of myxoid liposarcoma, where it is a very, very good drug. But for other sarcomas, I think some of these standard things like doxorubicin-based therapy are more likely to be helpful. But it's certainly on the list and we use it a lot. Other questions? Let's see.
How do you measure success from AIM treatment pre-surgery?
So an important topic, and I think that there's different ways to do it, but the key is imaging, right? So ultimately, when I'm typically giving AIM to a patient prior to surgery, my general recommendation is that we repeat whatever imaging we're using to follow your tumor, whether it's CAT scan or MRI or PET, after 2 rounds of therapy. And there's 3 possibilities, right? Either your tumor has grown, and even if it has grown, there are specific situations in which a growing tumor can still be responding to therapy. Another place where an expert review of your pathology can be helpful, but very often when a tumor is growing, that's a sign that the chemotherapy is not working. Tumors that are stable or tumors that are shrinking are generally tumors where I feel like continuing therapy is a reasonable thing to do. But I want to be careful not to speak to anyone's specific situation, but you want to have a careful review of the imaging by someone who knows what they're looking for. And that imaging should be done frequently prior to surgery.
How does an oncologist determine 5-year survival rates with and without chemo? If I use chemo, how much does my survival rate improve?
So, our crystal balls are not great, right? And so I think what I can quote a patient when they ask a question like their 5-year survival is a number from a clinical trial, which may or may not accurately represent that patient's situation, right? And so I'm generally, if a patient directly asks me what's the median survival for my cancer, I will tell them what the clinical trials show, but that usually does not speak to the specific circumstances of a patient. And I would be very careful about generalizing that kind of information to the specific person that you're talking about. So if a patient tells me how likely am I to live 5 years with and without chemotherapy, I can talk about populations of patients. I usually can't talk about that patient. And it's true that even for a patient where I say there's a huge benefit to chemotherapy, chemotherapy may not even work for that patient. And so what I would say is we can quote trials, but we can't tell you what your 5-year survival is. Tools like the Sarculator can help us guesstimate these things, but they are just that. They are estimates.
Okay.
We've got time for one more quick question.
Okay. Let's see. Okay. How about, is there a time frame after surgery when it's been too long for adjuvant therapy?
Yeah, I think that it's pretty clear that the sooner you give it after surgery, the more likely it is to be helpful. Is there a hard cutoff? Probably not. But once you're getting into the range of 3 months, I think I start to say that, it may have been long enough that the benefits have diminished some. You're going to get different opinions on that, depending on who you talk to and depending on the specific subtype of sarcoma that you have. If you have a cancer for which we know chemotherapy is absolutely essential, for example, I wouldn't let, having it been 4 months since your surgery stop me from recommending that chemotherapy. And so situation specific, but sooner is better.